I know we've gone through ARDS and we still stand at a very high mortality. We still stand at a very high mortality, 40 to 45% is the mortality when it comes. It is 10% of the ICU admission. So 1 in 10 patients that you're going to have is going to be ARDS. 1 in 10 patients is going to be ARDS. So on an average, you can assume that you're going to see quite a number of patients during your entire career in critical care. You're going to see many and many. So that is the reason that this being the domain of critical care, people will not realize how to, other physicians will not really understand how to treat these cases. Because it's not physician based, it's completely related to intensive care based. ARDS, we talk about ARDS. Okay. But importantly, what they found in one of the studies is that very few actually monitor the plateau pressure, and only 2/3 used lower inflection points, lung protection ventilation strategies, and only 8% prone. This is what they found in 2016. Okay, even today, if you see the patient that we intubated in the morning, I don't think you monitored the plateau pressure there. I had to come and do it in the morning. Same patient that you ventilated today morning. Today morning you ventilated a patient. What you should have done? You should have immediately seen the plateau pressure, seen the driving pressures. Did you do it? No. So unknowingly, even though we've been taught, you don't do it because it's not part of your daily protocols. You know, it is supposed to be a part of daily protocols. You are understanding what I'm saying? See, even in spite of you clearing your IDCCM, you still did not see the plateau pressures. You are understanding what I'm saying? So this is how true that even if you are actually dealing with ARDS, you aren't really dealing with ARDS. You are just again ventilating your patients like any other patient. So what did we find when we did that? What was the tidal volumes? What was the mistakes?
400.
What should it have been?
Predicted running.
And what it should have been?
300.
So 100 ml difference. 100 ml difference is a big difference between ventilator-induced lung injury and not. 100 ml. So if you don't follow the protocol, you don't go into lung protective ventilation strategy. So you didn't use low lung protective ventilation. You didn't use plateau pressures. You didn't measure it. And we didn't need the protein. So let's take this out of the equation. So understand, practically what I'm saying is, if you don't do it practically, you will never do it otherwise. You will never do it otherwise. So it has to be part of your daily work. If it's not a part of your daily work, you will never realize this. Are you understanding? So in the morning when you all took your rounds, each one of you all, did you all even concentrate on the plateau pressure? Did you all concentrate on this when they gave you the over? You all didn't. In your over, all of you all were there in the over, right? Did you all ask what is the tidal volumes that you have generated? Is this the right volume? Have you followed lung protective ventilation? Did you find the plateau pressure? None of you all did that, isn't it? Why? Because it's not there. You're not thinking like that. You have to think like that on every patient that you're intubating into the ICU. Because 1 in 10 patients are going to be ARDS. Are you understanding? So there are few very important things that cannot be omitted when you are looking at management of ARDS, and that goes in a stepwise pattern like how you have in brain. Here also you have a stepwise pattern as to how you should approach patients of ARDS. There are certain things that are must-dos. What Dr. Vaijanti just now taught was not a must-do. It is something that you may do. Okay, you may do because of the fact that it has not been proven on evidence-based medicines per se, but whoever uses it will probably vouch for the fact that it doesn't need evidence to actually say that it does something. You understanding? So in that bargain, there are a few things that we need to do here. First thing, it is 100% important to actually start the patient even before confirmation of ARDS on 6 ml per kilogram of predicted body weight. This is very essential. It's very essential. So if you don't do this, you probably are not even starting at 6 ml per kilogram predicted body weight. When we say predicted body weight, you have to measure height. Without the measurement of height, you can't really find out predicted body weight. None of us know what the weight is supposed to be. You can't look at it and say this is the predicted body weight. That is very important for us to. That is why to understand the height of the patient, with which you have the predicted body weight. What is the formula for predicted body weight?
50 plus 2.3 into height in inches minus 60.
So 45.5 so you must know the formula very clearly. So with that formula, you would get the kilograms, and that's how you monitor the tidal volumes. And we will be surprised to know that many of the tidal volumes that we give are definitely not right, unless you monitor the predicted body weight, and that is getting at least closer. Of course, we do things much advanced than that. We do things much more advanced than that, but this is the basic. Okay, we want to get this basic right in the first place. Advanced things comes only when you have got the basics right. If your basic itself is wrong, then what is the point of doing a transfer in pressure or reversal? You understand? So the basics are supposed to be right. Okay, and then you have to put it in the systematic diagnosis criteria for ARDS. So when I asked you PF ratios, asked you got the point what I was asking for. I was asking you these things, right? Which you have not noticed on written on your sheet. Because you first start the patient on 6 ml/kg predicted body weight, and then the next thing you say is try to fit it into the RDS criteria. Are you understanding? So you didn't do that. So anytime you ventilate your patient, the first thing you do is put them on 6 ml/kg predicted body weight, and then we do it next time. 6 ml/kg predicted body weight, and then we go ahead and do a screening for the ARDS diagnosis criteria. Now we are not into that as to what the diagnosis criteria is, but we all know about Berlin's definition, which actually talks about the diagnosis of ARDS as acute onset within the first 7 days, for PF ratios that vary from 100 to 200, right? And we are not, there are no nodules, infusions or otherwise, and there is no features of cardiogenic edema. So there are a few things that you need to figure out with respect to timing, with respect to pathophysiology, because you're looking at the X-rays to see bilateral fluffy shadows on ultrasound, which actually tells us that this is the ARDS. So after I do this, I need to move to screening my patient for ARDS, because everything further actually depends on that. Okay, so what is further about it? The further about it is once you confirm that this is kind of ARDS. ARDS it can be in different severities, right? But the treatment kind of remains the same. You don't change the treatment. Okay, you don't change the treatment. It may be mild ARDS, maybe moderate ARDS, it may be severe ARDS. What is our entire thing when we are ventilating patients with ARDS? To prevent ventilator-induced lung injury. Our entire thing is to prevent ventilator-induced lung. That is the basic thing. What are we trying to do? Prevent ventilator-induced lung injury. We are not here to improve oxygenation as of now. What are our first thing? Lung protective ventilation. We are trying to protect the lung so that biotrauma doesn't take place. We are trying to protect the lung so that multisystem organ failure does not take place. Every time you ventilate your lung badly, you are inducing multisystem organ failure. You are inducing ventilator-induced lung injury, causing biotrauma. Okay, so we are trying to prevent that. So when you are trying to prevent that, there are a few important things that without thinking you have to do. You have to figure out what your bladder pressure is. Okay, the bladder pressure has to remain less than 30. Your PEEP has to be more than 5, because we know that a PEEP less than 5 can cause problems. Okay, so these are few things that even without thinking you should do. Okay, you put this on, you see your predicted body weight, put in the RDS criteria, see the plateau pressure less than 30, you put the PEEP more than 5, and then only comes your PF ratios. Now if you don't have PF ratios, that's fine, do an SpO2 PO2 ratio, SpO2 FiO2 ratio, that can be done. Okay, so the PF ratios will come, and you come to the high, and then you think of high level of PEEP if it improves oxygenation. Then you think of neuromuscular corpus and throat position, and then you go to PV ECMO. So this cannot be omitted. Okay, this cannot be omitted. So if you look at each of these, the diagnostic criteria for ARDS, PF ratios less than 300, PEEP of more than 5, bilateral affair not explained by cardiac failure within a week of known clinical insult. This comes here. When you come up, then comes to moderate to severe, high PEEP test, more than 12, oxygenation improvement, hemodynamic, there should not be hemodynamic impairment, and we have to maintain bladder pressure less than 30. Then as we go ahead, prone position applied for more than 16 hours a day. You got the point. So this has to be done in this, and this is what is something that is again and again, time and again repeated, because not because we don't know, because we don't practice. Okay, we know it. In the exam, when you ask the questions, you'll probably talk about it. But if you're in practically with a patient, you may not do it. That's why you must remember to do this on a regular basis. So what is the tidal volume you need to give? So you need to give 6 ml/kg predicted body weight in any patient with mild to severe ARDS. This is clear. 6 ml/kg predicted body weight. It can't be 8350 or 400 or 450. It has to be 6 ml/kg predicted body weight. And this came from a study in 2000 which actually reduced mortality. Very few studies. If you actually Google and figure out studies that has reduced mortality, you will find a handful. If you look at randomized controlled trials in the literature of maybe lakhs and lakhs on PubMed of articles, lakhs of articles on PubMed, you will find maybe 10, maybe in critical care with randomized controlled trials well conducted, you will find maybe 10 or 12 articles which actually have changed mortality. You understand? So you can understand when there is a significant and a very well placed trial that has changed mortality, how significant it becomes. Are you understanding? Because there are few trials that have actually changed mortality, very few trials, a handful, and that is why you should follow this 6 ml per kilogram rated body weight, because the ARMA study, which is the Ards Net study, which is basically the Ards Net study, showed a 25% relative risk of mortality if you didn't follow that particular guideline. And all patients on ICU on sedation should probably have the same kind of criteria. And what they also say is to monitor plateau pressure on a continuous basis. And I at that time showed you how to do that. How do we do that, monitoring plateau pressure on a continuous basis? Put an inspiratory pause. The word is inspiratory pause. You put an inspiratory pause. If it is possible, put an inspiratory pause in the ventilation parameter to get the plateau pressure all the time on a regular basis, which will help you keep the plateau pressure less than 30. Even if the plateau pressure is less than 30, do not increase the tidal volume for ETCO2. Do not do that. Even if the plateau pressure is less than 30, say your plateau pressure of 10 and your tidal volumes are 300 and your ETCO2 is 45, don't try and normalize that ETCO2. Don't try to do that. You understand? Let it be 6 ml per kilogram rated body weight. In fact, you can get it even lower. Are you understanding? But don't increase it to 7 ml rated body weight. Are you understanding? Just because ETCO2 is 45, no, nothing is going to happen. Nothing is going to happen to your patient. So don't let the carbon dioxide remain elevated. No problem per se. No problem per se. But don't increase your tidal volume if your plateau pressures are less than 30. Are you getting the point very clear? So sometimes what happens is you are tempted to do this, because what happens, you are taking a patient, you have decided to put the patient on 350 ml of tidal volume, you have put 350 ml of tidal volume, you have done the ETCO2 is looking as 11 or 12. Then you think, okay, since it's not improving, ETCO2 looking at say 50, you look at the ETCO2 at 50 and you decide, let me increase my tidal volume and my RR. That is the first thing that will come into your mind, because I want to increase my minute ventilation. So you might increase the tidal volume, you might increase the RR, both together will kind of drop your ETCO2, no doubt. But what it will cause? It will cause ventilator induced lung injury, because you don't want more than 6 ml per kilogram rated body weight. It's a very important statement. Even if plateau pressure is less than 30, do not increase tidal volume. Do not increase tidal volume. Okay? P flat at this moment is more important than this figure called as driving pressure. Now, driving pressure is very simple to calculate. What is it?
Plateau pressure
minus P. Simple equation. Plateau pressure minus P when you get driving pressures. Now, what is this driving pressure? So, driving pressure was, even after so much of lung protective ventilation strategy in the year 2000 and so much of education all throughout the world, we still were not able to change mortality significantly. We were doing things, we were doing it better than what we did 20 years ago. But we still were not tremendously improving the patient's mortality. We were not trying, we were still having problems with respect to ventilating our patients with ARDS. So what did Marcelo Amato do? What he did was, he went ahead and looked at a huge category of patients of ARDS and looked at the whole studies that were there in ARDS. There were multiple studies that were done in ARDS. He looked at all of them and he kept understanding what is the parameter when kept right is improving mortality. So in that bargain, he did a lot of calculations and came to this figure called as driving pressure. It says plateau pressure minus P, which is less than 14. If less than 14, these patients tend to do better. This is what he came to. He came to that condition that if driving pressure, that is plateau pressure minus P, is less than 14, they tend to do better. But they at this moment have not been figured out as a target for ventilation. Or still your target remains tidal volume and plateau pressures. So it is more important. You want to look at driving pressure, no doubt about it, but I will not focus my entire brain on driving pressure only. If my driving pressure is low, I am happy. Okay, I'm happy. You understand? But I will not look at driving pressure first and look at plateau pressure. That's why when I wrote, what did I write first? Then I wrote? Are you understanding? Because it follows the same protocol. I don't change the protocol. Doesn't make sense to change the protocol. You change the protocol, you're creating problems. That's why I first write rated body weight, I put the tidal volume in place, then I put plateau pressure, and then I put my driving pressure. Because that's the order of importance. You understand? That's the order of importance. So you should also follow the same pattern. Even when you're taking your round on a patient on the ventilator, you should be following the same pattern. Is my tidal volume right? Is my plateau pressure right? Is my driving pressure right? Because this is what is very, very important. So understood for tidal volume is very simple. Keep it simple, it is easier. You make it difficult, you can make it very difficult. Okay. Now recruitment. There is a big difference between recruitment and peak. They are two different things. They are completely different things. Ashok, can you tell me the difference between recruitment and peak? What is the difference?
Recruitment, opening of collapse alveoli, and PEEP is preventing the collapse,
So-
preventing the alveoli to collapse.
Correct. So when you have ARDS, no, it's a heterogeneous lung. It's an extremely heterogeneous lung. Okay. There are areas of the lung that are inflated, and there are areas of the lung that are collapsed. Right. Entire problem that Master Amato and all these big people said was to have something called as an open lung ventilation strategy. When I say open lung ventilation strategy means I will open all the lungs together. Why do you think that is good, Chandrika?
Open lung strategy.
Why do you think it may be good? Physiologically, why do you think it may be good?
But it is not good, na, sir, because it
No, physiologically,
volume trauma.
so you feel it's not good.
Like if we try to inflate the lung all of a sudden, it will cause more volume trauma.
Okay, but if I want to keep all the lungs intact like this, open, versus some part closed and some part open, is there a difference?
Yes.
So what my question is very clear. You have a patient who has heterogeneous lung, where your alveoli is big, other alveoli is small. Now you have another patient, all the alveoli being big. Which
This
is
one
better?
will be better.
This one? Why? Why?
Because the oxygenation will improve with the.
I'm not even talking about oxygenation here. I'm not even talking about oxygenation here. Because oxygenation is not something I'm worried about now. We are all talking about lung protective ventilation. We have not even gone to oxygenation. Yeah? Anything?
Equal volume distributed to each and every alveoli, and is not one part of lung is over distended or over.
I'm not causing over distension. It's not over distension.
Airway resistance, sir.
So the entire point is, say I have a full alveoli and I have a small alveoli, and I'm going to give 500 ml of volume into this. I'm going to give 500 ml of volume into this. Okay, the pressure that is there in the joint of these two is very, very high because they are not homogeneous. So, for example, if this inflates more, it is obvious that if I give air here, this will not inflate as much as this one. Okay, so if this is small, this will inflate bigger. If this inflates bigger, this will stretch. Is that area between this alveoli and this alveoli will get stretched. That will cause biotrauma. The pressure over there becomes extremely high compared to the alveoli is big enough. So if it's big enough, air is what is stress? Stress is basically the force exerted by the air on a given area. Okay, so the force exerted in this bigger one is less, but the force exerted on the gap is very, very high. So if I have all the things together, the force exerted may be much lesser. It is all on this area. It's not in the gaps. It's not in those joints. You're understanding? No. So let me explain this to you. So you have an alveoli, okay, and you have another alveoli. Okay, this area is the joint between the two alveoli. I pass air inside from here. Okay, this part will get stretched. This part gets stretched, but the pressure here is found to be 4 times the pressure that is of this area. The pressure here is 4 times that the pressure is over here. You understand? By experiments, they have found in pigs, it's called as Mead's experiment, MEAD, Mead's experiment, where they actually put small chips of pressure transducers in the gaps of these alveoli and tried to figure out what the pressures were. And what they found was the pressure was 4 times. Clear? Clear? So if my plateau pressure here is 10, or my plateau pressure is 12, okay, what is my pressure I'm exerting over here? 40. You are understanding? You are understanding this? So if my plateau pressure that I am thinking is 12, my pressure here is enormously high. Enormously high. You are understanding? The pressure. So this will get amplified the more amount of collapsed alveoli you have interspersed with distended alveoli. And what will that pressure lead to? That stress, that is called the
Barotrauma.
stress. The force applied on that particular area is called as stress. That stress will increase, which will lead to biotrauma, which will lead to interleukins, which will lead to cytokines, which will lead to multisystem organ insufficiency. You understand me? I think I may have a slide of that also. Okay? That's why physiologically it makes a lot of sense to have all the alveoli to be equally opened or homogenized, or the entire lung to be homogenized into one segment, so that the pressure exerted on any one segment is not high. Clear? That's what the open lung strategy is all about. And that's what we do, that if we want to recruit our patients. So the thinking some years ago was, let's recruit everyone as a routine. Let us recruit. That was open lung strategy. You recruit your patients, and then keep the lung open. So when you recruit them, I am not only opening this, distending this, over distending maybe, but I am opening this alveoli. So when I open this alveoli with recruitment, I am ensuring that tidal volumes are going here as well as here, and my overall stress in my next ventilation for the next couple of days remains okay. You got the point? So the whole world felt that we should do this on a regular basis, and open lung strategy, ventilation strategy was one of the biggest things ever that was created in ARDS ventilation. Right? Unfortunately, we found out that this is not the scene. Unfortunately, this is not the scene, and then that is why routine recruitment now is not supposed to be done. So we don't routinely recruit. It's not this way. Patient is on ARDS, whatever, mild, moderate, whatever it is. You recruit your patient every day. Every day recruit your patient. No, we recruit only if it is required now. We've changed the entire policy from recruitment as a routine to recruitment as and when required. Clear? Because there have been side effects of recruitment. But what we have known for certain is we have to prevent de-recruitment. So if there is a ventilator or alveoli that is already big, you must understand this is ARDS. So there is interstitial fluid that is happening. This has very high chance of this also collapsing. So which is open, it is important to keep them open. And to keep them open, the only way we can do that is by ensuring that there is positive end expiratory pressure. There is no other way to keep it open. Okay? And what we know is two very important statements I'm going to give you is that a higher PEEP in ARDS is better than a lower PEEP. Very important statement. A higher PEEP is better than a lower PEEP. That is the first important statement. And the next important statement that I can tell you is, for recruitment, I will require close to 40 of PEEP. That is the genesis of the recruitment maneuver when we talk about PSI, when we talk about sustained inflation maneuvers. You've heard about sustained inflation maneuvers. What is sustained inflation? Put at CPAP, keep at 40, keep it for 40 seconds. The genesis of that 40 number is from a physiological approximation that says, to open up this lung, I require how much pressure? 40. Clear? So you understood what is recruitment? You understood what is PEEP? So can I recruit with PEEP then? It's not possible. I can't give 6 PEEP and say it's recruiting. No. To recruit, how much I require? 40. So will it make sense for you to do a maneuver and stop at a PEEP of 15? No. You have to go high because you want to raise the mean airway pressure, it is 40. Can you say oxygenation improved is recruited? No, it's not. Because you want what we know is that, there's a very important study done by John Michel Arnold, where actually they looked at different pressures to see where it opened up. It's a difficult study. What is the best way to understand recruitment? That you have recruited, successful recruitment, by looking at a CT scan. You do a CT, you do a recruitment, repeat the CT, if the lung is expanded, you have recruited. You can see on the CT scan, right? So they did like this in number of patients, which is so difficult to do. I mean, they did it at different pressures, and what they found was that when they are reaching pressures of 40, that is when the recruitment is occurring. And also importantly, what they also found, another important statement is, the recruitment occurs in the first 10 seconds. So you don't need to keep for 40 seconds. Whatever recruitment you get it for 10 seconds. In the first 10 seconds. After that that's why when we do an assessment for recruitability or when you're doing the recruitment maneuver, with the maneuver in the ventilator on a proper ventilator will be 10 seconds. Are you understanding? Maneuver will be 10 seconds. Clear? So two important statements, huh? Two important statements. Okay. What we know is when you give high PEEP, there is a 5% reduction in mortality. So can you give low PEEP? No, you have to give high PEEP. You have to give high PEEP. So PEEP of 5, when you say high, it means anywhere above 8. When you say high, it is anywhere above 8. Okay, so 7, 8 is what the ARDS PEEP that you will probably want to give. And however, if it is very mild ARDS, you may not want to give high PEEPs. If it is very mild ARDS, this is the moderate to severe ARDS. Okay. What about neuromuscular blockers? It's not to be used as a routine. It is not to be used as a routine. It is not that I'm going to put all my patients for 7 days on ARDS on neuromuscular blockers. It's usually indicated for the first day. On the first day, a lot of measurements that you need to do, plateau pressures, this pressure, that pressure. You want to prone, you want to do a lot of things. So that maybe you can probably give it for 1 day. Okay, so no, it's very important to be that it is not used as a routine. Okay, when do you recruit these patients? As I told you, we don't want to do it routinely. So there is no routine recruitment. But when do I want to do it? I want to do it whenever you have done an endotracheal aspiration. I want to do it when there is accidental or planned disconnection, or it is after an intubation. So these are the 3 important areas where you want to recruit your patient, especially this after this intubation. You have to put in the tube. You feel that you have achieved something that is very big. I know you have started your work. After you have put the tube in, yes, you've done a great job, but you need to recruit at that point, because what has happened is this patient is bleeding at a fast respiratory rate, lower tidal volume, and probably collapsed on his entire lung. So this is one place where you probably want to recruit them. I will not come next morning and again recruit them. No. That time, I am suspecting that this patient, and it's easy now with ultrasound in place, so many areas of collapse is there. Let me recruit my patient. If the patient's hemodynamics are okay, important to recruit these patients. Okay, intubation. So if the PF ratios are less than 150, I would be happy to use a continuous infusion of neuromuscular blockade, and not more than 48 hours. I would put it lower down to 24 hours actually. 24 to 48 hours is the maximum I would probably have to use neuromuscular blockade. Clear on this, on ARDS? Okay, prone. When do you prone them? You prone them if your PF ratio is less than 150 after 24 hours of full ventilation. So don't prone it on day 1. On day 1 you do a PF ratio, you find the PF ratio to be less than 150, don't prone. Give them the best form of ventilation. Give them the best form of ventilation. You will find that 50 to 60% of your ARDS of severe nature will actually respond in the first 12 hours. Okay, so give them 24 hours of ventilation, good ventilation. Let it be any mode which actually increases mean airway pressures, like APRV, like pressure control, like volume control with high PEEPs. So do all those things for the first 24 hours, because hypoxia doesn't kill. Hypoxia doesn't kill. You must understand that. Hypoxia doesn't kill immediately. Right? So you can maintain that for a while, for 24 hours, and 24 hours later, if your PF ratios are not improved, okay, I may consider a prone position. Right? And that is something that is very, very important, because prone position is the next trial in the entire Ards trial that has actually improved mortality. Okay, it is one of the few trials that have actually shown an improvement in mortality. It's one of the few trials that have actually shown improvement in mortality. So that's why I have to be clear when I have to prone my patient. You cannot just prone any patient. If you prone it the wrong way, it will actually not improve mortality, it will cause more mortality. If you prone it on day 1, you are losing your opportunity of nutrition, assessments, looking at the patient's pressure, ulcers, sores, everything, tube out. All these things can occur in the first, if you do it in the first. If you do it for longer time, this is a problem. Okay, and if you do it for the short time, it doesn't work. So you need to have it for 16 hours. That break of 8 hours is primarily so that you can do nursing care. Okay, let's now go to, we just come off this to TPP. Okay, this is about MRs taking the lecture for you in the past. All right. Oh, it's ultrasound and diagnosis. You want to get through this also? Let's see this. Okay. So when you go to ARDS, any kind of pneumonias, let's not go to this. Let me go to transforming pressure. Okay. So let's go to transforming pressure now. Okay. We're going to understand physiology of transforming pressure and how do you use it, how do you apply it to your usual care. Okay. I wanted to do this after our advanced sessions. So spontaneous breathing patient positive pressure ventilation. We are worried about what? The pressure exerted by your gas on the alveoli. I am concerned with what? The stress that the lung is undergoing is the force applied by the gas on that area. Force applied by the gas on that area. You understand, huh? You want to put this something? Pause. Very important thing is in ventilation. One is called as stress, other is called as strain. Okay, what is stress? Stress is the force that the gas is exerting on the alveoli. So I'm worried about what? This force. I'm worried about this force that we are exerting on the alveoli. You're understanding this force, okay? So if I know this force, if I know this force, whether I'm injuring or not injuring, because all we're talking about is plateau pressure, and that we have plateau pressure is the force that we are thinking. What are we thinking? That is the plateau pressure is the force, right? Huh? So in a spontaneous breathing patient versus a positive pressure ventilation patient, there is a net distending pressure. There is a pressure that is distending when you are spontaneous or when they are positive pressure, right? So when we talk about pressures, no, any trans pressure is inside pressure minus outside pressure. That is a trans pressure. Anywhere you see transmural, you see transalveolar, transpulmonary, whatever you see is inside minus outside. Okay. A corollary to that is the NIV. In the NIV, why do you give CPAP to these patients? Can you explain to me why NIV improves these patients of systolic heart failure? Can you tell me how it improves? Okay. You should read the book. The book that is there on television. You should read the book. Okay. How does it improve? So we are worried about pressure that the heart has to exert. This is your alveolus. Now this is your left atrium, right atrium, and this is your afterload. This is afterload, right? If I reduce, if the pressure over here is my important pressure here. Inside pressure minus outside pressure. So let's see inside pressure. Okay, inside pressure minus outside pressure is equal to trans pressure. Trans cardiac pressures. Inside pressure minus outside pressure. Inside pressure I can't change. It is a radius. It is the radius of this. I can't change this. Inside pressure, it just remains the same. But outside pressure is what I'm exerting from outside is your PEEP. So when I put a PEEP over here, what am I doing to the whole equation? It is coming down. Transfer pressure. So the afterload is actually coming. You understand? So the thing to give when you cardiogenic pulmonary edema is I want to reduce the afterload, isn't it? To reduce the afterload, I need to give some kind of reduction in the pressures in the afterload, and for that I need to do this. I need to give PEEP. Are you understanding? So if I have a patient with systolic heart failure, apart from drugs that I can use to reduce afterload, that is nitroglycerine, I would want to use CPAP. That is why when I come in and I see the patient not on CPAP, I come in and put on CPAP here. Because CPAP there is therapy, it's not for oxygen, it's not for respiratory rate, it's for therapy. बोला क्या सुनने को? ठीक है? So in this case, here also, inside pressure minus outside pressure is your transpulmonary pressure. Clear on this? Clear? This is not come out, this coffee is not come. See this Slim Shady? You see this song, Slim Shady? No? You know what Slim Shady? It's not my generation, it's your generation. So Slim Shady was a fantastic rapper, was involved in a lot of controversies. So he had a song called as Will the Real Slim Shady Please Stand Up करके. So will the real transpulmonary pressure really stand up? So you have airway pressure, you have transalveolar pressure, you have pleural pressure, you have plateau pressure, you have so many pressures. You have so many pressures. So which is the real pressure? That is the question. Which is the real pressure that you look at? So there is so many pressures. No, there is airway pressure, there is transalveolar pressure, there is plateau pressure, there is pleural pressure, there is transthoracic pressure. Which is actually the real pressure is the question that we have, isn't it? Which is the real pressure? Which is the outside, no? Okay, so for that you must understand the pressure time curve. for the volume oriented breath and the pressure oriented breath. So the pressure time curve shows airway pressures, time. Airway pressures, time. Okay, this is as simple as that. This is pressure control, this is volume control. We now last time discussed how they look. Variable pressure, so it's volume control. Constant pressure, so pressure control. Here this is, if you ask me, this is patient triggered, pressure triggered, volume limited, and cycled by time here.
Time cycle.
TLC. You understand TLC? Breath type is TLC there. Here it is triggered by patient,
Patient triggered. Limited by pressure.
limited by pressure, cycled by time. Right? So this is a pressure oriented breath. This is a volume oriented breath. Clear? Now again we go back to this equation. I think we have done this. Okay. So have you remember this? So the airway pressure here, P1 is the airway pressure at the mouth. This is the airway pressure at the alveolus. It's looking at this pressure. Okay. So when the airway pressure is more than the alveolar pressure, air will move from outside to inside. Simple. What we are seeing over here is resistance of the airway. So since P1 is more than P2, you are having the genesis of this curve. Okay, that means the pressure is slowly going up. The pressure that it is monitoring here is slowly going up. Okay, clear on this? Pressure is going up. Then that is why the alveolus gets distended. That is, the distension that it is getting is the compliance. The ability to distend is the compliance. So the compliance is the ability to distend. Okay, so it reaches the peak. When it becomes the biggest, the pressure reaches the peak. Right? And then what happens is, the P2, this compliance will stop, and it's called elastance. Elastance is what? Elastance is the tendency to get back to its condition. The tendency to get back to its condition is elastance. So every lung has its elastance also. Okay, so the elastance will cause the lung to actually now it will stop at one phase. It will first stop. If I have an inspiratory pause, it will stop. At that phase, the flow will stop. Because I've stopped it, P1 is equal to P2, the flow is completely stopped. That's why you get the plateau pressure here. You get this plateau pressure here. Clear? When the plateau pressure moves off, okay, then P1 becomes less than P2, so the gas has to move outside. Since the gas has to move outside, the flow is started again, and elastance causes the alveolus to actually go down. You get this kind of waveform, the alveolus collapses and the patient goes into expiration. Clear? Now the thinking is that area, when you are reaching here, at least in this diagram, it looks like the pressure that I am worried about is the pressure that is exerted right here. It looks like that, isn't it? But what is important is it's not only here. This pressure is not only improving the alveolus or distending the alveolus, the pressure or the force is actually going to not only distend the alveolus, also distend the chest wall. It has to raise the chest wall. So that means if I want to give a certain amount of pressure, that pressure will go to distend the alveolus as well as distend the
Chest wall.
raise the chest wall. So my pressure is not going to be used just to distend the alveolus. It is going to be divided to the chest wall also. And this is exacerbated when there is obesity, when there is fluid resuscitation. So for example, you have a patient 2 liters you resuscitated. That fluid is not going to go and stand only in the vascular circulation. It's going to come out, go to the chest wall is going to get heavier. You understand? 2 liters is 2 kilos. It's going to get heavier. So your 30 millimeters of pressure will probably go to also inflate the chest wall. Clear? Clear on this? So that's why to actually figure out the actual pressure that is exerted on this wall, on the lung, I have to figure out this pressure or the entire pressure and remove this pressure out. Right? And that's what I'm trying to do. Transpulmonary pressure is equal to alveolar pressure minus pleural pressure. So I have to take out that pressure that is there, chest wall pressure, which I'm taking as pleural pressure. Clear? So that's why my transpulmonary pressure is now alveolar pressure minus pleural pressure. That means the net distending pressure required to distend the lungs is this figure that I'm going to get here. Right? Now, if you think about it, if I want to recruit my lung, I will require this to go to how much? 40. Clear? Now let's go further. Okay. How do you get your pleural pressure? You get it through esophageal manometry. That is how you get your pleural pressure. You get your pleural pressure through, there is no other way to do it. Esophageal manometry. The other way is to put in a catheter inside the pleural and measure the pressure. It's not possible. It's not possible. So we take the surrogate of that, which is the esophageal pressure, and that's what transfer pressure is all about. So let's take an example. This is your alveolus. It's at zero pressure. Your pleural space pressure usually is -3, -4, -5. So what is your transalveolar pressure?
3.
Huh? Your transalveolar pressure is
3.
how?
0 minus
0 minus -3. 0 minus -3 is +3. So your transalveolar pressure becomes positive. If it's positive, that is a pressure that is exerted in the alveoli, it will keep the alveoli open. It's positive, no? It's going to keep it open. Clear? Huh? Clear on this? Now let's go to the transalveolar pressure over here is +3. So at the alveolus is open. Okay. So in a spontaneously breathing patient, all of us over here, our transpulmonary pressure is positive. That is why we are not like any of the patients that are there in the intensive care unit. Alright, now let's take a pneumothorax and understand why the lung collapses now. Okay, we hear pneumothorax causes lung collapse. We hear that on a regular basis. How does that happen? That happens this way, that once you put a drain inside, or once you put a pneumothorax over there, there is zero pressure there because the pressure is approximated to the atmosphere. The pressure is zero there, right? Since it is because -3 निकल गया, zero हो गया है वो. Okay, when it becomes zero, 0 minus 0 is 0. So the transverse pressure is 0. So there is a chance that the alveoli will collapse. Okay, there is a chance that the alveoli will collapse. Clear on this? Simple? Huh? That's why when you have pneumothorax and you don't treat it quickly, the lung collapses. You clear? And the lung collapses. Right? Now let's see, when I have pressure controlled ventilation, what is happening? This is pressure controlled ventilation. Okay, I have pressure controlled ventilation of 10, I have PEEP of 6. But say I have my patient on the ICU and this patient is on the supine position and the patient you have resuscitated, the pleural pressure becomes positive because there is fluid. That's why you do your ultrasounds. When you do your ultrasounds, you have these patients with collapse on the lower lobe, some small amount of pleural effusions you are seeing. That small amount of pleural effusions will make my pressure to be positive. It will no longer be negative inside. You got the point? Huh? So when it becomes positive, say 6. What is my transverse pressure? 6 minus 6 at the end of expiration. At the end of expiration, this is at the end of expiration. This is constant throughout. So in inspiration, it is expanding. But on expiration, it is collapsing. Are you understanding? That is why we have patients with pleural effusions having collapse. That is passive collapse. Clear? Now let me put the effusion to be higher. A good amount of effusion. Huge effusion I have now. Okay, it's made the pleural space to be 12. Okay, now 6 minus 12 is minus 6. What will it do? It will collapse the alveoli. That is why when you tap a pleural effusion and once it collapses, how much pressure it will take to expand again? We drew that alveoli. 40. Once it collapses, how much time will it take to expand?
40.
Are you and me generating 40? That is what do we need? Incentive spirometry. Are you understanding? Are you understanding what we are trying to do? You understand what I am saying? Huh? So is it possible that you just tap your patient and you say you're fine, go home? That is why what we do, we try to mobilize them, we try to put them on incentive. For example, that ICD wala patient down there.
Supriya.
What is important there?
Mobilization and spirometry.
Spirometry is so important because it is almost impossible to expand that alveoli which is kind of collapsed unless you get the pressures to 30 to 40. When what can you do? You can't put pressure there. She is spontaneously breathing. The only thing you can do is increase the volume. If you increase the only way to increase the volume is by increasing the force that she is generation to increase. That's why that incentive spirometry should be 2000. should be 1500. When you give such high tidal volume she's taking or breathing and breathing out or whatever, what is going to happen? You are trying to open up that alveoli with that high pressures. Are you understanding? That is why incentives spirometry becomes extremely important in such cases. Alright, it collapses at expiration. That is very, very important. So if I have a patient of pressure control ventilation, I'd like to increase the PEEP. Okay, if I increase the PEEP, that is when it will negate my pleural pressure and kind of keep the alveoli open. Okay, if it again goes to more than 20, the same problem. How will I know this? How will I know this pleural pressure? Only if I have a catheter. Only if I have a catheter, isn't it? Only if I have a catheter. Okay, there is no way to actually figure out this. That's why even a high PEEP becomes a problem. If you give a high PEEP, your transabdominal pressure is markedly positive, there can be overdistension. So PEEP is not the answer. PEEP is not the answer to everything. Optimal PEEP is the answer to everything. The optimal PEEP. So you've understood this entire thing. You've understood why it's important to measure the transpulmonary pressure. So let's go to the concept now. Now let's go to the concept. The concept that I was trying to make you understand. That concept. Okay. So this is our patient of COVID. No? The patient of COVID, peripheral opacities. Peripheral opacities. Yeah, we're very used to this CT scan for the last 5 years or so, 4 years or so. We're very used to this CT scan. Now, we are fortunate to actually measure functional residual capacities in these patients. 1500, 500. What is the strain here? Tidal volume divided by FRC is your strain. Okay. This is your baby lung. Okay. When you say baby lung, it's a small lung. It's not a stiff lung. It means the volumes are reduced. Volumes are reduced. So what is the FRC here? The FRC has gone from 1500 to 100. That means the existing volume in which you can put the gas is only 100 ml. And the tidal volume, if you give the same tidal volume to this particular patient, you're going to have strain of very, very high sharp trauma. Strain is very, very high. 0.5. It's 0.5. It's very high. Now, same tidal volume, but what is the strain? The strain is the absolute volume delivered related to the baseline volume of the lung. So here you're giving 500 and 1500, here you're giving 500 and 100 ml. What is more dangerous? This one. That is why when you have ARDS patients, in ARDS patients, it is important to have lower tidal volumes. You understood? I'll explain this once more. You have a normal lung and you have an abnormal lung, maybe a kind of normal lung and a very, very abnormal lung. Okay, now let's take the FRC of this particular patient. Say the FRC is 1500 ml. So here you have an entire area that is completely down, which you see in our CT scans. Okay, that means here the functional residual capacity that you have at the end is very, very low. Okay, here the amount of air volume that is there in the lung is low. Volume here is low, volume here is high. The same tidal volume if I give from outside to this patient and this patient, that tidal volume which is normal for this patient will be injurious to this patient. Clear on this? Clear on this? So the absolute volume that you're delivering is actually dependent, the volume that you're delivering is actually dependent to the absolute volume that exists in that particular patient. Are you understanding? Clear on that? Clear on that? So that is why this concept is very, very important for you to understand. And there is a good relationship between stress and strain. Stress is equal to K into strain. This is the relationship. Where K is actually a specific elastance. Let's just remember this. Stress is equal to K into strain. Okay. Now, let me explain to you what stress is here. So, stress that we talked is force exerted on a specific area. Force exerted on a specific area. Force is after all baro, is pressure. That's what barotrauma is all about. Okay. So, barotrauma is airway pressure, that means airway pressure outside, minus pleural pressure. And that airway pressure that we are monitoring this by plateau pressure. And what we are monitoring by pleural pressure is usually estimated by esophageal pressure. It's an estimation. So that's how you get your stress. That's how you get your stress. Right? Clear on this? And what is your strain? Your strain just now we discussed. What is the strain? Is your tidal volume that you are putting in the relative amount of tidal volume, in the amount of absolute volume that you have in the lung. Right? Absolute volume you have in the lung is FRC. And what volume you are putting is the tidal volume. That's the strain. That's what we discussed just now. Strain. Right? So the strain is equal to tidal volume divided by FRC. This is called as volume trauma. Now you understood the difference between barotrauma and volume trauma because you all talk the same things together. Whenever you are talking barotrauma, and you don't know what is barotrauma, you don't know what is volume trauma. right? What is volume trauma? Volume trauma is the amount of volume to the relative amount of volume to the volume that is already existing, right? So if I were to increase my tidal volume, okay, my strain will increase, and if my strain increases, my stress will also increase, because the relationship is K into strain by K is a constant. So it is interlinked. The volume trauma is interlinked to barotrauma. You understand? It is interlinked. But as a concept, volume trauma is tidal volume divided by FRC. The FRC is the size of your baby lung when you are doing ARDS. When I say baby lung, means small volume. Clear? Clear on this? Am I clear? Can I go ahead? You can go ahead. You've understood this equation, very important equation. If you understand this equation, you will probably understand the whole lung only. That's how it is. Alright. So now this K is actually a constant called as 12. It's a specific elastance. It's 12. Okay, it's 12. This is what they have found. That K is 12. Right. So that's why you will reach a total lung capacity. Okay, when there is a strain of 2.5. So 2.5 into 12 will be the maximum capacity of the lung. Maximum capacity of the lung will come when I actually multiply this by 2.5. 12 into 2.5. Right? What is 12 into 2.5?
30.
Huh?
30.
30. So that is your plateau pressure that you are keeping now, isn't it? You are understanding? What is your plateau pressure thinking? 30. Huh? So 12 into 25. 12 into 25 is the highest limit of the injurious stress. You understand now plateau pressure kaisa hai? 30. You understand now? Huh? That's why the strain that we want to keep in our ventilator should be this number. That's why the strain. And how do you calculate strain on our ventilator? We have got a button called as functional residual capacity. You press the functional residual capacity, you will get the FRC. That tidal volume divided by FRC has to be this, lower than that. If you go lower than that, you are probably lower on the plateau pressures also. So, clear?
So the strain has to be always less than 2.5.
Yes. Yes. It's obvious. No? By this equation, it's obvious. No?
Yes.
By this equation, you can understand that if I were to actually have strain more than that, because there's a relationship of barotrauma and volutrauma, you will induce barotrauma. Are you understanding? So if you have a patient on a tidal volume of 500, 500, 500, 500, 500, when he is actually requiring 300, though 500 is low, when you and me are 800 and 1000 ml we are at. 500 is low, but it is very high for that baby lung. It is causing a strain, and that strain reflects to the stress, causing pneumothorax and pneumomedias. You're understanding? Our problem is we don't know what is that tidal, what is the, we know the tidal volume you're giving, but we don't know the FRC. Most of the ventilators outside than what we're doing in our ICU. Here we know the FRC. Since we know the FRC, we are objectifying our strain and thus our stress. So that's why we have this, the elastance actually remains unchanged. This K remains unchanged even in severe ARDS. Elastance doesn't change, compliance changes, but elastance doesn't change too much. That's why that constant remains the same. That constant that we talked about as well, that kind of remains the same. The specific elastance remains the same because what we know from ARDS patients is that the elastance is not changing. You understand? What I'm doing is all concepts. These are all concepts that I'm talking, not really gone clinically. Okay, now I will explain to you what I was talking to about in atelectasis and stress razors. Okay, so this is all my alveoli are inflated. All my alveoli are kind of in the open state. I give a volume, it inflates all the alveoli. Right? Now I have one alveoli in the middle that is collapsed. Okay, I have one alveoli that is collapsed. Among all these alveoli, one alveoli is collapsed. Now what is happening is, if I apply a volume, everything else is opening, I am applying the same volume. But this is not opening, right? This one is not opening. It's not going to open because how much volume, how much pressure you require? 40. It's not opening now. 40. You have to give 40 pressure, then it will open. We are at a low tidal volume. It's not going to open that. And that stress razor they found out over here is 4.64. I said 4 times. 4.64. The stress razor is 4.64. So 4.64 into TPP into the transfer pressure is the actual pressure exerted. So if your transfer pressure is 12, your actual pressure exerted is 48. You understand? That's why I want to keep my TPP as low as possible, especially when there is collapse here and there. Are you understanding? What do we know now? What we know, this is in peak studies. This is in peak studies. When we actually look at human studies, this stress razor is somewhere around 2. Okay, stress razor is somewhere around 2. Now what is this? 4.64. If I have a TPP of 21, I have pressures of 97. It's very high. Okay, it's too high. Okay, it's too high pressures. You understand, huh? So, what we know is that these pressures are somewhere around 2 in human beings. What that was, Beats trial was from pigs, okay? When they did it in human beings, they found out this pressure is equivalent to somewhere around 2. That is why what we want is a transfer pressure into 12 agar pakdenge. Stress should be less than 25. That's why we want the transfer pressures to be really less than 25. In fact, less than 12. That's why your TPP has to be less than. Understanding? You want your TPP to be less than 12 because of this reason. That's why TPP has to be maintained at 12. Less than 12. 0, 1, 2, 3, 4. We want to keep it positive. We don't want to keep it negative. We understood why we want to keep it positive. And how positive to keep it? You cannot keep it to 15 and 20. Because when you keep it to 15 and 20, your stress razors will cause it to be much more higher. I want to keep it less than 25 because my stress is less than 25 plateau pressure. My stress has to be less than 30, right? 30, I want to keep it at 25. My stress, I want to keep less than 25 actually. Right? 30, less than 25 is even better. That is why what transfer pressure I want? 12. Because 12 into 2 is 24. This is what was explained during the workshop. You understand? Huh? You understood this concept? Have you understood this concept? Any questions on the concept? Any questions on the concept? It's a concept, okay? And this will explain to you why, what values you have to keep at the transpulmonary pressure, why it needs to be positive and how positive you can keep it. So, because you might think I can keep 16, if positive I keep 16, no, why not 16? 16 will cause problem because your plateau pressures will go even more higher. Your stress will go even more higher. Clear? Any questions here? No. Simple? Okay. So the drivers for our ventilator-induced lung injury, now you will understand. Now that you have understood these few concepts, you know very well, if I increase my P very high, what can occur? My transpulmonary pressure can go up, my TPP can go up, right? TPP will go up because the pressures are increasing there. So it can be causing ventilator-induced lung injury. Other way around, if you keep it low, there will be collapse. The stress razors will increase. The stress razors will increase. So I can't keep 0 PEEP. At the same time, I can't keep very high PEEPs. Both extremes are going to cause your lung to get damaged. I know for certain my plateau pressures. This I know from much of data that says plateau pressure less than 30 is very important. I know that. Now I know that driving pressures also seem to be important. Less than 14, and now you must be clear that why your tidal volumes are so important, because the strain depends on your tidal volume. Clear? So that's why the focus on mechanical ventilation should have these focuses. You should focus on these parameters when you're actually looking at ventilation. Now tell me, the next patient that you're going to be on mechanical ventilation, if you don't write this, are you doing justice? Are you understanding? That's why it's important to note these parameters very well, because that causes ventilator-induced lung injury. Right? Alright. So, okay. Okay. So now, what happens with low pressure? What we know for certain is those patients who undergone resuscitation or who are obese, their pleural pressures are high. That we know for certain. Okay. Now, this is what the Ards trial was all about. Marcel Amata was there. Okay, this is what it was. It was a small trial if you look at it. Number of patients were very less. See, 29, 24. Okay, but they did find out that mortality did change in this particular, almost 7% absolute improvement in mortality, 6% improvement in mortality. Okay, there was a change in this. As compared with conventional ventilation, the protective strategy definitely was better. And then when you go to lung protective ventilation, what they also found, what was clear in this trial was also the fact that if you were actually do it this way, your amount of interleukins, polymorphonucleosides, interleukins, all were lower. After all, it is that causes inflammation, all the problems. So what you are telling is, as time moves, the interleukins actually go lower. See, here it has come down. Here it was, you understand what I am saying? Interleukins actually coming down all over, all TNF alpha, interleukin 8, interleukin 6, all of them are coming down, clearly indicating that there is a clear role of something like this. Okay. Now, importantly, you must also understand that intra-abdominal hypertension in critically ill patients is normal only in half your patients. So, if you have a patient on the ventilator, what the fluid you are giving, most of the fluid is going where? Into the splanchnic circulation. That's a bigger part of your circulation. Your arterial circulation is very low. You understand? Effective arterial flow is much lower. Rest of the flow is all splanchnic. So udhar sab ja raha hai. So in your abdomen you have maximum fluid going. Abdomen and chest walls. That's why only half your patients, less than half your patients at abdominal pressure is normal, especially those who are resuscitated. And why am I talking about this? Because this pressure will also cause the fluid pressure to go up. This pressure will also cause, because the compartment is related. There is a pleura, there is abdomen. Abdomen pressure will go to the pleura. Are you understanding? So there is going to be a transmission of pressure. Since we are talking about pleural pressure, we should know that what the pressure is over there. So there is going to be a transmission. Okay, and there is almost a 58% transmission of pressure when it is around 16 to 27 centimeters of water. Bladder pressure. That means Vaijayanti was talking to you the other day how to measure pleural pressure without the esophageal manometer. If I have my bladder pressure, I can get an approximation of my pleural pressure. How? It will be around 58% if it is in this range. Are you understanding? And if it is above 27, it will be transmission is only 8%. So in this I cannot calculate, but here I can actually say that 58% of patients the bladder pressure will probably translate up. There is a formula for that. Now she explained the catheter. Okay, now this is just a revision of what she has explained now. How do you verify the position? We discussed inside the stomach, watch follow up, cardiac oscillations. We see first cardiac oscillations. First you put it fully inside. Around 55 to 60 approximately will be the depth when it goes inside, 550. Okay, it goes inside, you put it totally inside, you will first need to just see abdomen. So when it totally goes inside, before it goes inside also you verify whether the cuff is proper, everything is fine, then you put it inside. Don't put it with pressure, it's not like rice tube. It has to go absolutely lightly. If it is going with pressure, it is not in the right place. No pressure at all. Okay? It has to go inside with the guide wire. Once it goes into the stomach, switch off everything and press the stomach wall. How do you inflate this? You don't inflate the balloon, you're inflating the whole catheter. So you can inflate by putting the three-way open to the catheter as well as to the ventilator. You understanding? So you inflate and then press the abdomen. When you press the abdomen, there is no movement in the airway pressure, means you are in the abdomen. Only the esophagus pressure is showing. Okay, that's what Dr. Vaijayanti showed you. Okay, that is the actual midpoint of the esophagus where you probably need the catheter to be. And what we know now from data is very clear that esophageal pressure is very close to the pleural pressure. Esophageal pressure is very close to the pleural pressure, very, very close. Okay, and that's why it is close to the transpulmonary pressure also. That's why you can monitor the transpulmonary pressure using your esophageal pressure, and the airway opening pressure is equal to the transpulmonary pressure. Okay, that's how it is. Okay, so now this was the trial that Dr. Vaijayanti told you about. How do you set? You can do a lot of things with this. With transpulmonary pressure, esophageal catheter, it's not just setting beep. You can do so many things with transpulmonary pressure. You can actually figure out what is your tidal volume inspiratory pressure, titrate the recruitment maneuver, inspiratory can determine efforts, and it can actually figure out patient ventilator asynchrony. It's too much for you as of now, but I'll tell you a practical application. The formula to use simply. Okay, what is simple over here? You measure the plateau pressure. Let's call it P plat inspiration. Plateau pressure. Let's call it P plat INSP, P plat inspiration. inspiratory plateau pressure. Okay. At the same time, measure the esophageal inspiratory pressure. Okay, clear on this? When you are doing plateau pressure, whatever comes on the screen in esophageal pressure and whatever you see as plateau pressure, note it down. Okay. The end inspiratory transfer pressure is P flat inspiration minus inspiratory. Clear? Okay, that is inspiratory. Keep the TPP end of end inspiration less than 25. We just now discussed that. We just now discussed that keep the transpulmonary pressure less, the stress less than 25. Okay, so we are keeping the stress less than 25. Clear? Now expiratory hold, look at the plateau pressure, let's call it P flat expiration. Same time, measure the esophageal expiration, which comes as P minimum. Alright? And its expiratory transfer pressure is P flat expiration minus P esophageal expiration. Keep the TPP more than 0 and less than 10. More than 0 and less than 10. Clear? समझ में आया? हाँ? अब ये क्या है? ये तेरा प्लेटो प्रेशर है एक्सपिरेटरी होल्ड पे. एक्सपिरेटरी होल्ड में क्या हो गया? पूरा का पूरा प्लेटो प्रेशर तेरे को दिख गया. My pressure inside has to be more than my pressure outside. Ashok, be in tune. If you don't understand, stop me. Okay? No problem. So we are beyond. Placement हो गया. Placement में वो pressure वैसे होता है. Placement हो गया. Placement में होता है pressure वगैरह. We are beyond all that. Now what are we seeing? We are seeing a volume control mode, and we are seeing an esophageal pressure that is going. This is what you are seeing, right? Now what I will do? My calculation for transpulmonary pressure is inside pressure minus outside pressure. And when I say outside pressure, I am meaning pleura, right? So inside pressure, when I am saying is P flat, plateau pressure at inspiration, that is plateau pressure, minus P, I am removing the pressure that is exerting on the chest wall during inspiration. Which is that pressure? P max esophagus. Esophageal pressure, that is P max. I am removing the pressure that is required to inflate the chest wall. समझ में आ रहा है? हाँ, तो ये आउटसाइड प्रेशर हो गया. हाँ, इनसाइड प्रेशर हो गया ये, बराबर? Minus outside pressure. Outside pressure क्या है मेरा? I am already putting one PEEP inside, right? So that PEEP minus outside, that is at the end of expiration, that is P minimum. So if I press my P flat button, if I press the plateau pressure button, I will get two pressures. One I will get plateau pressure, and at the same time I will get my P max. I'll get my P max, right? I'll put that into this equation. Similarly, when I look at my PEEP, positive experiment, either by doing an auto PEEP maneuver, what I will get? I'll get my PEEP over there. I do press the auto PEEP maneuver. When I do an auto PEEP maneuver, I will get what PEEP? That number I'll put over here. Minus at the same time by P minimum. You're understanding? And that answer will be my TPP. And now we know TPP has to be 12. समझ में आ रहा है? Clear? Clear? So now if I want to use this for, now look at this over here, okay? So what have I done look at what we're looking here is P max. You have done at P, every pressure end expiration is P, end expiration is P, P max is here, P plateau is here, at the same time the esophageal pressure maximum is here, P plateau end of inspiration is here. Right, so I am taking this pressure, okay. So if you look at here, end inspiratory transpulmonary pressure, P flat inspiration. P flat inspiration is here, okay, minus P inspiration here. End expiratory is P flat, okay, P flat. Expiration, that is an expiration at the end of expiration. Yes, P flat at expiration. This one down here, I mean here, at end of expiration, minus esophageal pressure at expiration, that is over here. this I am minusing with each other. So here it is 17 as the P plateau pressure, so you're getting this value over here. What has happened here? You're getting 17, okay, at end of inspiration.
So that is end inspiratory, sir.
So when you're doing this, when you're minusing, putting this into this equation, I'm getting TPP of minus 13, which means this lung is going to collapse. Which means this lung, even the PEEP that you're given, in spite of the PEEP that you're given, this lung is going to collapse because TPP here is 17, no? The TPP here is 17, that is at inspiration, is 17 minus 20 is minus 3, okay, and expiration is, plateau expiration, whatever is minus 13, okay. For example, here is 5, here is 18, so it is minus 13. What is the, even though this picture looks completely normal, this means this patient is collapsed everywhere. You are understanding? You understand, na? It's completely collapsed patient. Nor is the stress proper, nor is the strain proper. Right? That is why if the easier option how to manage these patients on the ventilator is to follow this formula. So you do the first step would be, this is a simple protocol that we can probably use for all our patients who are on TPP monitoring. First step would be monitor the end expiratory transpulmonary pressure. Now that you know what end expiratory transpulmonary, you understood what is end expiratory transpulmonary pressure now? I go back here to show you that. TPP end expiratory is P flat end expiratory, that is P flat end expiratory is here, that is your PEEP. Minus P esophageal end expiratory, that means at the same point the pressure that you're getting here is what you're putting over here. That you're putting over here, that is what you're monitoring. What that has to be? Always positive. You understand? That has to be positive. उसको तुमको पॉजिटिव रखना ही है क्योंकि उसको अगर नेगेटिव रख दिया कोलैप्स तो 100% है. Clear? Now once I do this, the next step would be to put this table in place. This is a table that was generated from this study. An EP vent trial was done, so it's good to use this particular table. Okay, where we use oxygen management table. Now look at what's happening over here. What does this mean? Now my patient is in the esophageal catheter. I have adjusted my PEEP to prevent expiration, to prevent expiratory collapse. I have adjusted my PEEP to prevent expiratory collapse. I have done that much till now. To prevent expiratory collapse. Clear till now? Now I want to improve the oxygenation, right? So what do? I will look at this table. So if my FiO2 is 0.6, I now want to keep my transpulmonary expiratory pressure at 2. So till now I just kept it positive. Now what do I want to do? I want to keep my expiratory transpulmonary pressure depending on this table. So if I'm at FiO2 of 10, I want my TPP at expiration to be 6. So I will keep altering my PEEP. Because over here PEEP minus P esophageal pressure. You got the point? So if I have end expiratory transmission at 2, for example, if I have TPP of 2, but my FiO2 is 100%, how much should be my transpulmonary expiratory pressure? 6. So to make it 6, and this is 2, I will need to increase this to 8. So I will increase my PEEP to 8. Understood or no? Once more. So the first step is to figure out what your end expiratory transpulmonary pressure is, which we now understand how to do it. Okay, that is my first step. That is why whenever you have put this, first I say this is what I first say. Okay, now once you keep this positive, what I can understand, my lungs are not going to de-recruit. My lungs are trying to keep it open. Now my FiO2 is say, then I look at my FiO2. If my FiO2 is say 100%, the minimum FiO2 they are giving 100% to maintain 88 saturation. is 100%, then I have to increase my this figure to 6 as per the table. Right? Now this was 2, or let's consider it as to be 0. If it is 0, in order to increase this, I have to increase my existing PEEP by plus 6.
What was 2? I didn't get that.
This was 2. Say this was 2 for example, or let it be 0. Let it be 0. If this was 0, say this PEEP was say 8, and your expiratory this was 8. So 8 minus 8 is 0. 8 minus 8 is 0. Now what I want to do? I want to get this to 6. So what will I do? 8 plus 6, 14. So I'll keep my PEEP as 14. Clear? You understood how my PEEP adjustments are? Clear? It's very difficult for you. Okay? Okay. For them only it is so difficult. Clear? And there is another step on this also. This is what that step was. We just not talked about step 2, the same step. So at 0.3, 0.4, 0.5, don't worry. 0 bhi chalega. 0 bhi chal jayega. But once it starts going up, I want to change my PEEP. You understanding how? Samajh mein aaya abhi? Because I want to keep my TPP at a certain number.
Fixed.
Clear?
FiO2, depending upon FiO2.
Depending on FiO2, minimum FiO2.
So why is that?
That's the table. That's how they found out. That is what I'm trying to tell you, that this particular trial gives us an answer how to do it simply. Right? Then, so this is how you titrate upwards the PEEP to get your optimal PEEP. You understand? You can titrate it like this to get your optimal PEEP. Clear on this? Weaning. Now, when you want to wean, okay, once you have reached the PEEP, when you have reached this kind of settings, where your FiO2 is 0.4 and a PEEP of 14, I will start weaning my patient. Once I get to these figures, PEEP of 8, FiO2 of 30, PEEP of 10, FiO2 of 30, I will start changing. That's the entire point. Okay, I'll start changing this like this in this order. I'll start changing this in order. So if you follow the protocol this way, it's simple to do it. If you plaster this somewhere, put it in your phone and keep it ready, it's simple to do it. Alright. I think that's exactly what this tells us, just tells you the same thing again, nothing different. So that's about transfer pressure. You understood? I just put you a simple, so the few things that about this is to understand this part of the story. Okay, to understand this part of the story, and to understand how to use it to set your PEEP. Okay, this is only one part of it. It's not recruitment, it's not strain, it's only PEEP. It's only how to set your PEEP using transpulmonary pressure. It's too much for to begin with, if you ask me, but this is what it is all about.
It's just to keep your lungs open and recruit. Open.
Yes.
Not recruited.
This is just to keep your lung open. This is a kind of an estimate.
Avoid collapse.
Yeah, it's kind of an estimate. You understand? It's kind of an estimate to understand that. That's the only thing about it.
So
That
why do you tell the difference between TPP inspiratory minus expiratory?
that's your actual TPP.
That's your actual.
That you want to keep as less than 12. Sorry, Maharaj? That 25 number is your inspiratory. You understand? That's your inspiratory. Your actual TPP is inspiratory minus expiratory. You have to minus that out. That's why it comes to 12. You understand? 12 into 2 is 25 plateau pressures. Sorry, Maharaj? That's how the plateau pressure generation comes in. Clear? So I didn't want to do this, but okay, we've done it. Any questions on transfer pressure? Any questions? Vaijayanti, so this